Right, so our next session is Radical Innovation for a Resilient Health Service. And in this session, we're going to consider how the NHS can take full advantage of innovation to boost its resilience for the future. The NHS has begun to adopt whole population health management, genomics-based medicine, detail and data analytics to embed transformational change across systems. But as we know, questions remain about how to ensure resources are allocated fairly across systems and how technological advancement will transform our healthcare delivery. So our panelists are all considering these long-term strategic concerns for the NHS. I'm going to welcome them all on stage, and they're all going to speak for a few minutes before a discussion and questions from you. So we're joined by Professor Pali Hungin, OBE, who's chair of the Changing Face of Medicine Commission, Academy of Medical Royal Colleges and Newcastle University. By Dr. Julian Sheether, who's Specialist Advisor in Ethics and Human Rights for the BMA, and by Chris Hobson, who's the Chief Strategy Officer of NHS England. Sadly, Ming Tang, Chief Data and Analytics Officer for NHS England, was due to join the panel to discuss data analytics and supporting population health management, but unfortunately is unable to join us in Liverpool today. But welcome to all of you. And as I say, we've got about up to 5 minutes for each of you to set out your thoughts on this before we go into a discussion. So can I ask Pali first, if you'd like to share your thoughts? Hello.
Thank you. Thank you very much, Samira. This session is very much about boosting our resilience for the future. This makes it important, therefore, for us to consider what the future might look like. And of course, the context of my very short presentation is the fact that within the health service, we are so concerned with dealing with the problems of today and immediate problems tomorrow that it's actually very difficult to project ourselves into the future. The Changing Face of Medicine project, which I chair through the Academy of the Medical Royal Colleges, is a think tank of young people, essentially young doctors and also representatives from industry and from the public. And we have been working on trying to visualize and to create scenarios which project us into 10, 20, 40 years ahead. You can see some of our work on our website, which is entitled The Changing Face of Medicine. And what I would very briefly like to do is to cover some of the areas that we've been dealing with. So, for example, looking at the future, one of the areas we've been looking at, not surprisingly, is technology, including medical advances, informatics, and artificial intelligence, but not just what things might change, but also the relationship that these will have with people in health and with organizations. Importantly, we've been working on the whole big area of the huge social and anthropological change that's occurring within society. What is the future relationship between the public, patients, and health givers, particularly doctors? And we appreciate very much that whilst continuity of care and human contact is a valuable commodity, which is greatly needed by all of us as patients, yet this is something which in the future could be a very thinly provided commodity, something that might be supplanted by other methods and other approaches. Dare we think into the future, say 20 years hence, when we will be so pleased because it took only 2 weeks to see a GP and 3 years to get a hip done? The future isn't always something that gets better in terms of what we feel we need. Clinician well-being has been an important topic for us. We recognize that doctors, particularly suffering from burnout, not doctors alone, nurses and others in the health system, pose a huge risk to the way the present system is configured. Where are we going to be in the future with regard to our own staff? What are their needs? Is, in fact, the delivery of health in the way we perceive it almost impossible for the human who is delivering it? What balance between that sense of vocation, that sense of duty, the ability to enforce technological advances whilst remaining very human? Visionary leadership is one of the other areas which we have covered. And we have found a huge deficit there, and we've felt that as far as the future is concerned, a lack of visionary leadership is going to lead to an inability to plan for the future. We can all cope with what might be coming, even if we are in difficult times, if we somehow have a plan to cope with it and we become aware of what might be in the pipeline. It gives us something either to plan for or to hope for, certainly something that makes us interested and excited about the future. We certainly felt in one of our think tank meetings that our current models of leadership, which are often geared towards effective management, do not actually facilitate imaginative global strategies for the future, and that we need a different visionary approach, not just from our clinical leaders, but from individuals who go to medical school, nursing school, and certainly our administration colleagues in the NHS. We also challenged the approaches to medical education. In fact, one person asked startlingly, will there be a need for doctors in 40 years' time? Will they not be supplanted by a whole group of other professions and by technological achievements? And by the fact that pharmacogenomics and personalized medicine will become so specialized that the individual delivering care within the current model may not actually be necessary, and that many of the technical jobs that are done in hospital settings may be performed by highly trained individuals, perhaps assisted with machine-learned equipment that knows what to do. These are important areas, and again, I stress that unless we all lean back and think about them, we will not be able to touch them. So all I need to say is to my colleagues in the audience, those of you who are chief executives and others in roles of important administrative control, if you have any control, what I need to say is, in addition to the firefighting, in addition to the daily organization, in addition to the innovations that are being put in on a day-to-day basis, please, if you can, set up a separate, safe place group where individuals can be trained in scenario planning, where your whole organization can learn how to think about the future, consider what might be coming in the pipeline, and to start to prepare for it. The world is evolving fast. Things are evolving. Look at the way general practice is evolving. It may not exist in its present format for very much longer. Look at the way hospital services are evolving and the way integration might be going. These are important challenges, and we need to be able to cope with them in the future. So my request is set up a careful, thoughtful think tank for your organization to start considering the future and what might be required. Best plan now than to say we have no resource for that. Thank you.
Thank you very much. Julian, thank you.
Thank you very much. What a real pleasure to be here. So 5 minutes, resource allocation, no problems at all. Interestingly, of course, we're here to talk about innovation, and yet what we're confronting is one of the oldest economic problems of all time, which is scarcity. In particular, how to allocate valuable goods when they are scarce and need overwhelms supply. Traditionally, of course, generally, loosely, markets have done this with their kind of cold magic. As scarcity increases, costs rise, fewer people can get access to the material. Fine if we're talking about fast cars, perhaps, caviar, but health is different. We know that health is different. We know it's a foundational human good, and without access to health services, we struggle to lead the kinds of lives that we want to lead, and markets have no interest in fairness in the distribution of goods. Fairness is not the issue in markets, it's ability to pay. In health, we have chosen, as we heard earlier on from the Labour Party, to socialise health. It's such an important good that we've protected people from the terrible moment of thinking my health is failing, I cannot afford to treat myself. But the state is different. A state is different to a marketplace. A state has moral obligations to treat all citizens fairly. And in that context, how do you make decisions about how to allocate resources when there is simply insufficient of those resources to go around? How do you approach that problem when every single need is legitimate and the state has a legal and ethical obligation to treat everyone fairly? Now, I've been in ethics, working in ethics for 25 or 30 years, and I do not have an answer to that question. There is, to the best of my knowledge, no stable answer to that question. If we talk about rights and the clamour of rights and people saying, I have a right to treatment, well, how do we make the decisions? If we talk about cost effectiveness, if we say, actually, we'll try and prioritise the most cost-effective interventions, what happens? People with rare, hard-to-treat conditions can be marginalised, can fail to get access to the treatment they need. Other attractive approaches, a lifestyle approach. There is something morally, intuitively attractive about the idea that we should try and allocate health resources to ensure that people live as much of an ordinary natural lifestyle as possible, which would prioritise early interventions in care. But we know we don't have such an NHS, and we also know that would ride roughshod over the rights of elderly people to treatment they require. So we are really on the horns of an allocative dilemma, and we do not have an easy way out of it. And in those kinds of circumstances, we shift focus from the substantive moral content to the procedures by which we make the decisions. Procedural justice comes into play. And the innovative bit of this very brief few words on this ancient problem is that we need, as a matter of urgency, an open and honest and courageous discussion with full public engagement about how we are going to go about allocating these scarce and incredibly valuable resources in contexts where we cannot meet all serious health need. Thank you very much.
Thank you, Julian. And finally, Chris.
Well, it's great to be here. This stage, this conference, with all of you, indeed this lectern that I remember standing at 10 years ago when I did my first speech as the NHS Providers Chief Executive. Look, it's the first time that I've really had the chance to, see you all together in one place. So would you please indulge me for just 2 minutes? And I literally do mean 2 minutes. Look, we've all got our own view of leadership, but for me, the concept of stewardship is really important. And I think if you're a leader of either an organisation or a part of an organisation, it's your responsibility to leave the organisation in better shape than when you took up your role. So I really hope you all feel that as I departed NHS Providers, that your organisation, and I want to stress it's your organisation, was in better shape than when I first stood here 10 years ago. And I think as a leader, you also know that you've only actually, in the end, got a really very small contribution to the organisation's success. So I did want to be a little bit cheeky and just very quickly do 3 thank yous and a congratulations. The first thank you genuinely is to all of you. I do honestly believe that membership organisations are only as good as the degree to which their members support and engage with the organisation. And I have to say, I could not have asked for more when I was your chief executive, both in terms of your engagement with the organisation, but the personal support that you gave me as somebody who was completely wet behind the ears, never kind of come across the NHS at all, and the patience and understanding, but also the support you gave me. A second thank you really to, and again I know Saffron was talking about it in her speech this morning, but just one of the things that I think we've managed to do over the last decade is build up an absolutely fantastic staff team, and I hope you will recognise that that's been a labour of love, but actually, if you don't mind me saying, how lucky we are to have such a great staff team and a senior leadership team. And my third thank you is a particular personal heartfelt one to Saffron, who I have to say, I really genuinely felt that we co-led the organisation almost right from the beginning, and I was particularly pleased when she became formally the Deputy Chief Executive, and I'd just really like to thank her in particular for her patience and understanding over the last decade. I know it's been much needed. And then finally, the congratulations is obviously to Julian. I mean, the torch of leadership passes on, but having worked with Julian on a number of different occasions, I know that he will be a brilliant leader of NHS Providers, so congratulations to him. So to actually now talk about what I was meant to be talking about, which is innovation. One thing very quickly, Samira, which is I do bring apologies from my colleague Ming, who basically, I think as you probably know, it's been an interesting week for NHS England. As you know, on Thursday there is a fiscal event, and that's meant that the organisation has really had to focus on that for much of the week and much of last week. So she gives her apologies and sorry she's not here. I do think we need to recognise, and again, it's a kind of truism, and everybody, I think, has probably been saying this today, is that the service is under significant operational pressure. And one of the great things about my new role is I do have the opportunity to say, from my new vantage point, just a really big thank you to both all of you, but also to all of the staff teams that you lead for your kind of continuing commitment and professionalism in the face of that pressure. And again, I don't know about you, but I kind of feel quite strongly that effective public service leadership is about continuing to serve the public as best as we can and lead our frontline staff as well as we can, no matter how great the pressure. And I know the pressure is very, very significant. And I suppose the point I really wanted to make, my big sort of, in a sense, kind of theme is, we know that when the operational pressure is greatest, there is an inevitable pull to focus on the short term. It's why we're doing so much work to improve the urgent and emergency care pathway with a particular kind of focus on improving ambulance performance and improving discharge. It's why we're putting so much effort into ensuring that we recover not just the elective backlogs, but also community and mental health backlogs as well. But the bit I think is particularly difficult but particularly important is to kind of maintain that balance between, on the one hand, the focus on what we're doing today to solve today's operational pressures, and on the other hand, the importance of focusing on the long-term transformation at the same time. And it's a very, very difficult balance to strike. And I do worry sometimes that we sort of get into it's either or when it clearly needs to be both and. And I suppose my observation would be that as I go round and as I look from my new vantage point, you just get that real sense of all the levels of the service in terms of individual providers, ICBs, NHS England, all kind of struggling hard to kind of strike that balance. But it's really, really clear, isn't it, that unless we can kind of get that long-term transformation right, actually, that is another way of solving today's operational problems. So the four themes that I just wanted to, and literally, they're just literally sentences that I kind of have got, I think we've all got, and I've got in my mind, are really four areas, four key themes on that longer-term transformation. The first is integration and system working. We've created ICSs as statutory bodies. We know they're on a journey, but it's really, really important that we push that journey as hard and fast as possible. The second, which is I know where Ming would have wanted to concentrate, is on data, digital and technology. And again, I thought Wes was saying, and I know others have said it earlier, is just the importance of really focusing on data, digital and technology as drivers of new models of care. The third is just the massive opportunities that 21st century genomics-based medicine, that's my sort of Chris Hobson sort of summary phrase, the opportunities that brings. And then fourthly, prevention and whole population health management, some real opportunities to think differently about, again, as Wes was talking about, the opportunity to go upstream and to ensure that we actually invest greater amounts of money and greater amounts of focus in prevention, but also managing our whole population. But for me, the key, the challenge in a sense that we've got, I think, as a service at the moment is to not only address those immediate operational pressures as effectively as we can, but also at the same time make sure that we're devoting appropriate focus to those longer-term transformational themes. Thank you.
So I'll start with some questions just share within the panel, and then do start thinking about what questions you'd like to raise with them. You raised, Pally, this idea of, the need to set up a kind of think tank and have this long-term strategic planning. I wonder how far you think health leaders are genuinely engaged in that type of long-term strategic planning for the kinds of innovations we're talking about.
Yes, that's a very good question. I alluded to the fact that so many of us in our trusts are dealing with immediate problems of capacity and all sorts of other difficulties. And in fact, the capacity problem is such that it's very difficult to take staff out or to create time and space to start thinking about the future. It's a terrible sort of a metaphor, but it's almost as if we're watching evolution without having any control over where it might lead us. And I think it would be much better if we were able to create this safe area with some of the most innovative people in our trusts to think about where we're going. The world is clearly changing. There are pressures which are causing patients to act and to present themselves in ways that were so different from a few years ago. The arrival of iPhones and other technological things has changed the way people feel and think about medicine. Medicine has become so much more democratized. We can each look up to see what our problem might be. The relationship with the clinician has changed. The kind of questions we ask and the balance between the professionals and the public is shifting. And the arrival of the technologies is going to have a huge impact on this, not just in technological terms, say, of doing operations automatically, but certainly also in the way early diagnosis and accurate diagnosis will be made. I think without working out the potential demands from the public and how we can deal with those, even within our relatively restricted staff base, because that's not going to suddenly double or triple in 2 or 3 years' time, I think we have to think in a different way, and we haven't got the capacity to do that.
I wonder if the next logical thing, and all of your views on this would be really interesting, is ultimately we're talking about making the patient a bit more of a custodian of thinking about their healthcare. So that might be the empowered person who already looks at things up on Google and comes in with an idea, or is happy to have a quicker consultation online rather than wait for an in-person appointment. But there are real challenges with that, aren't there, about people's access to digital technology, their confidence, and their background in terms of how they feel about taking that kind of initiative. So I wonder what your thoughts are about the role of the public in thinking about innovation. Do you want to take that first?
I'm an ethicist, and for me, this concept in the clinical encounter of patient autonomy, patient choice, empowerment, that's front and center, and has transformed thinking about certainly kind of medical law, bioethics over the last 20 or 30 years. But as you say, it has challenges. It has some challenges around equity. Not everyone has equal access or equal ability. It tends to favour the articulate middle classes, people who can go in and push their GPs.
But you could argue the NHS already has that situation where so much of it is
absolutely. It just may intensify if we're not careful. I mean, I think it's the way forward. Absolutely the way forward. Patients as custodians of care. I also want a little bit to not over-egg the kind of technological pudding. Because actually, we're medicalising the world, we're medicalising human experience, and that puts an enormous amount of human experience into a medical context where technology
Our patients not medicalising their experience by becoming
that's part
empowered.
of it, absolutely part of it. So I'm aware that there are challenges, but absolutely I think front and centre we should be custodians of our own care. We should be, take our health fate in our hands as far as possible, but recognising that there are some risks about that. And medicalisation, advertisement, people, advertising, people saying, well, look, this is a health problem. You want to treat this as a health problem. There are risks out there, unquestionably. But I think front and centre, yes.
Chris?
Well, I do think there's a very interesting opportunity, isn't there, in terms of changing the nature of the relationship between patients and the NHS over the longer term, in terms of we know that if the model is to be sustainable over the longer term, Wanless was saying 20 years ago that the real importance of encouraging, facilitating, enabling and supporting our citizens to take greater responsibility for their own health and well-being, and that effectively avoiding a dependency model where effectively the NHS was just a national treatment service, and where effectively we had clinicians whose job it was to effectively treat illness as opposed to encourage and, as I said, enable, facilitate and support people to look after their own health and well-being. And that's where I do think if you take a 15, 20, 25, 30-year view, you can absolutely see how the combination of technology, but also the way in which you might think of the role of the healthcare professional. You know, I mean, the conventional word or phrase that's used is the idea of health coaches. You can see that offers opportunities to really turbocharge that kind of one-less vision of how do we ensure that we shift upstream to ensure that we're focusing more on prevention. But, if I may say, I think both my colleagues are absolutely right that the equity issues here are really, really important. And, you know, we know that there is, one of my responsibilities in NHS England is for health inequalities, and we know that when you get these shifts in models of care, you can very easily leave people behind because they don't have access to the technology, or, you know, they have differential levels of ability to look after their own health and well-being.
But you can't stop the march of social and anthropological changes.
Completely agree, Paddy,
You can't stop things just to make them more equitable.
Agreed.
But how do you, sorry, forgive my
Would you like a glass of water?
Do you need a doctor?
water by itself isn't going to do it. So I know I'm in a room full of professionals.
You dial 111.
So if I need any help, I know I'll get it. I've just got to catch in my throat. What do you suggest, Pally, is the way to think about engaging the public with this issue? We talked about the challenges, but how do you see this innovation for patient autonomy actually potentially working for the NHS?
Well, as a doctor, I think that we ought to open a public dialogue, certainly start speaking in terms of limited resource, but also the way things are developing. I mean, I know, for example, that probably there is no one in this room who hasn't had a friend or a relative in whom there hasn't been a delayed diagnosis or a wrong diagnosis. And that public expectation has changed completely. We've gone from an age when people said, well, mustn't grumble, or thank you for having taken care of me, to one where expectations are different. And I'm not sure that we're able to respond to that without being perfectly honest. And I think we need to be more open in, not just in public debates, but in our writings and amongst ourselves about the way things are changing and how we may or may not be able to meet such expectations. Equally, yes, of course, I'm a doctor and I want to save my job, but it may be that we need to shift the way we work. Perhaps we have far too many specialists, and I think that the long training system may be highly inappropriate for something like the National Health Service, and that many of the jobs that are being done by highly specialized specialists might be done by people who are trained in a completely different, shorter manner.
I mean, this is the kind of stuff that really is exciting but also worrying, isn't it? Because if you're talking about really changing the way the system thinks and compartmentalizes, that's very long term, it's very disruptive. And again, I just wonder what the rest of the panel think about how far we can start developing those ideas, given we're in this climate when there's so much pressure on just responding to need right now.
Incredibly difficult, isn't it? I mean, from my perspective, these issues at that scale are political. Trying to incentivize people to make small and meaningful health changes in the face of a kind of catastrophic decay of a health system is not an easy call. So I think we are looking around for some political solutions to that. But I'm absolutely committed. Go upstream. The investment in health needs to go upstream. It needs to tackle the determinants of poor health. We've seen it in the social determinants of health, but also the environmental determinants of health, etc. It seems to me that that's where we need to focus. I mean, technological solutions have a huge place, but they're not the core, I think, of the kind of future when we're talking about people being custodians of their own care.
Yeah, Chris.
Yeah, well, I do think theories of change, sorry, it's very dull, isn't it? Theories of change, actually, I find really interesting, and I think that one of my favourite kind of, quotes on change is that wonderful Bobby Kennedy quote of effectively, actually, large-scale change is the aggregation of a whole series of individual small changes. And one of the things I would observe that I feel over the last 10 years I've seen in particular organisations is that real focus on enabling frontline staff to make changes at the front line. I mean, I think of, you know, the guys in Surrey and Sussex. I think about what Julian's done at Leeds. I think about what Marianne Griffiths did in Western Sussex. Just that real kind of sense of taking a systematic approach to enabling, listening to your frontline staff, enabling them to put through a series of what might seem actually quite small changes, but actually when you add them together, making a really significant kind of change in terms of outcomes, but also kind of patient experience and staff experience. So yes, we can talk about at the end of, you know, big technological change, we can talk about big political change, but we also just need to remember that there is the opportunity to use improvement methodology to effectively drive smaller changes that, when added together, actually add up to a big change.
It's a really interesting question that's come in. How far does innovation go? No sane system would start from here. We still have too many silos and points of approval. Ultimately, health and social care are two sides of the same coin, and the only reason we divide them as we do is because of cost. Have we gone through the looking glass? You're talking about needing to change the way we think. I mean, that's a really interesting view of the current system, isn't it?
People would argue that we need a shift in our social structures as well. Again, I'm simply reporting to you some of the thoughts that have come out of our think tank.
Yeah.
One of the thoughts is that, well, I mean, this may not be a popular statement, but that offspring need to start to learn how to look after their parents when they get older, much more than previously so, that our changing social structures have caused this divide, whereby elderly care, and particularly social care of those with multiple morbidities and so on, seems to be in the domain of the state. But I just want to not take so much issue, but discuss with you the point as to whether politicians or politics is at the heart of improved health. I think in this particular area, not. I think the future of medicine and that of doctors and that of nurses should be in our hands. We know what our profession is. We know what pressures and difficulties we're undergoing and how best we ought to and should deliver care. We should be the leaders here in partnership with our politicians. Otherwise, the system is incredibly slow. It runs from a top-heavy approach and doesn't keep pace with what's happening at ground level. I feel we've abdicated some of our professional responsibilities here. Again, lack of leadership.
Chris and then Julie.
Yeah, I do think genuinely that integrated care systems do offer, I mean, we've now put them on a statutory basis. We've been on a journey where they started out as sustainability and transformation partnerships. They were non-statutory ICSs. They're now statutory ICSs. I really do think there is an opportunity to do things differently, particularly in relation to the question talking about two sides of the same coin. But we just need to recognise that, you know, there's a lovely phrase, isn't there, about giving structural changes the chance to grow and stop pulling things up by the roots every 5 minutes to look and see how they're doing. Actually, just let them grow. And my observation would be, so where are we? We're sort of 6-7 months after them having been created as statutory entities. If you'd sort of looked on a graph and said, how far would you have wanted them to have got within that 5 or 6 month period, I actually think they're doing extremely well. And I think we all have a responsibility, and there's been a debate, hasn't there, about the relationship between providers and ICSs, is I think we all have a responsibility to make these structural changes work effectively, because I do think they offer a fantastic opportunity to address some of those very long-running issues around, you know, the siloed, you know, breakups, in a sense, in the provision of care between health and social care.
Did you want to add anything, Julian?
I'm just going to agree with you, sir.
ICSs
are the way forward, and you know, efficiency is ethically fundamentally important, and it is just a way to drive efficiency.
It's a nice question that's come in. Is the national health and care system trying to do everything on a restricted budget, rather than provide the basics on a realistic budget and do that well? Radically changing means designing a different approach and a different investment scheme.
That's for the ethicist.
Yeah, I mean, that is where the debate needs to be had. I mean, that was what I was calling for. Can we, to what extent can we realistically fund healthcare to the level that professionals want, that the public want? Can we fund that? What models work, and if we are forced to ration because we simply don't have the resources, what sort of rationing is acceptable, both morally, legally, and politically. That's where the debate's got to be had.
Anyone else want to add anything on that?
Well, there is a slight flaw there, isn't there? Because if,
I'm sure you're right, Alan.
if we, say, settle for excellent basic care within our funding envelope, then what about the person who might benefit from an expensive treatment and has the means to pay for it and gets it? You're immediately back to your lack of equity.
Yes, we have the lack of equity is there now, and it may well, and such a decision and such a pathway, it's not, I'm not sitting here saying that that's the way we should go, but choices down that pathway will have unquestionable significant equity costs. That's why we need to get into that debate.
Well, there's a good question here that sort of picks up from that. Helpful 4 themes from Chris Hobson. Picking up data and digital, how can NHS England support the levelling up in community and primary care, in this case to ensure staff are digitally enabled and empowered? But it's...
Well, I think our responsibility in NHS England, as we put in the new operating framework, is it's our job to set the overall national strategic framework to ensure that there is appropriate funding, obviously working closely with government. And I think one of the things that we've done in the digital and data space over the last few years is get clearer, moving away from the idea of a whole series of individual single point digital solutions to just being clearer about exactly where we are going to concentrate and also what we're looking for from that framework. So, for example, it's got to be right as a nation that we have electronic patient records throughout every single hospital, and that we need to put the effort into ensuring that not only are those systems in place, but they're also then operating collectively so that you get interoperability, ensuring that there's link up between the different parts of the NHS. And then again, as we were talking earlier, about ensuring, for example, investment in an NHS app so that we are enabling people to use that app to take greater control of their own care. So the NHS England job, it feels to me, is to set that national framework, ensure appropriate funding, listen very carefully to what ICSs and providers are wanting in setting that framework, but then effectively, as we've said, give ICSs and give providers the space to lead.
I'm going to come to audience questions next, but there's one more that's come up, and it's come up in previous sessions. I've not had a chance to raise it, which is thinking of health inequalities. What are the plans for ensuring equal access to dental care in England? Because it is in crisis. And I'm interested in thinking about innovative thinking. I mean, there's a very specific challenge, isn't there?
Yes, in many ways this reflects our previous discussion. I think that basic emergency care is available and children's care is available, but those who can afford it and can go privately are able to get care beyond that. So we have a system that has evolved in its own way, in its own right. That's regardless of external political influence.
But again, it's the way that dental care has sort of been hived off from the core of the NHS. So yes. The standards of NHS care in the dental services are really, I mean, the idea that people are waiting a year or can't even find a surgery which will take them on the NHS.
Right.
It's remarkable. Sorry, I didn't mean to interrupt your flow, just reflecting on it in my own head.
My sister's a dentist, so I suppose I'm a bit of an authority. I don't know how to answer your question. I think that it's a dilemma that dentists themselves find themselves in. You know, they're keen to deliver high-quality care, but I think that because of the need to maintain income and to maintain effective practice care, there's obviously been a hive-off. Whether or not sections of medical care might be hived off in the same way is worth thinking about in terms of scenario planning. If you don't consider all options and possibilities, then you're either shocked when they happen, or you haven't prepared yourself for them, or you haven't managed to avoid them by circumventing them. This illustrates me the need to think for the future.
I think for me, what we're seeing here, I mean, are we in dentistry, is care available free at the point of need for those who need it when they need it? I don't think you can say that that is the case in dentistry. And that presents a model and a risk, and for many a threat for the ways in which NHS care may go in the future. And I think we need to think about that very, very clearly. Because you can imagine just slowly slicing things off, salami slicing it, saying, well, look, that's not life-saving, that's not absolutely core, begins to dismantle. And I think we need to have a real open and honest debate about, is that the way we want to go? Are we just going to be drifting there by thousands and thousands of cuts? So we end up there without any decision or any agreement that that's where we want it to go, because the whole system begins to disassemble because it's starved of funding.
Yeah, physiotherapy is an example.
Well, I started out,
physio is an
some
example.
people in the audience will know, I started out my career in politics, and one of the golden rules was never underestimate the intelligence of the great British public. And I think what's interesting is when you ask the public what they want a national health service based on the principles of care available, free at the point of use, based on clinical need, not ability to pay. And when you then dig under the research, where quite understandably at the moment there is a degree of concern about the NHS, particularly at the pinch points, but actually what people say is we want an NHS that is appropriately funded, which has got the right workforce with the right skills, and is capable of effectively delivering the care that we would like. And I mean, there's a lot of kind of noise at the moment in terms of the model, but the British public, overwhelmingly, we're talking about 80-90% of kind of people in these opinion polls are really clear that's what they want. And I think you can't help feeling that, I don't want to stray into politics because I'm not allowed to, but, that it feels like it's kind of government's and the NHS's job to basically meet that requirement of what the British public want.
Yeah. If we can raise the lights a bit, if there are questions in the auditorium, I'd love to take them as well as the ones that are coming online. Definitely one from number 1 over here. Thank you.
Good afternoon, Chris. Jack Tarsing, Coventry and Warwick Partnership Trust, at the front to your right.
There you are. Hi, Jack. Good to see you.
So my question is simple and easy. It's around health inequalities. They're avoidable and preventable. If they're avoidable and preventable, then why are we having a debate about dentistry where people from certain postcodes, certain ethnicities, certain disabilities are having this inequality? And if that's a political decision that's been made to hive off a particular service, then what should we be doing? And how do we get, the question really on innovation is, how do you get innovation to focus on reducing inequalities that are then not creating an inequality, as I think we talked about fairness, because fairness is also a concept I think everybody in here would have a different view on. It's equality of outcome we're trying to achieve through innovation.
That's a really nice, concise idea, isn't it? How do you get innovation to work to tackle inequality?
Well, so first of all, to say thank you very much indeed, Jag, for your leadership in this area. And, consistently over the last decade, you've basically been, drawing our attention constantly to it, including at the NHS Providers Board. So I think the answer to the question is, again, I'll go back to our role. Our role is to set a very clear national framework. Bola, who I think is in the audience, who was here earlier on and is part of, I have the privilege to be her line manager, we've set out really clearly about how with our Core 20+5, we've set a national framework saying this is the framework we want individual local organisations and local systems to use to identify what is best for them to do in their local area with appropriate innovation. And I think you just need to be careful about making the assumption that, innovation comes best from the centre. I think for me, it's about how do you enable local organisations to effectively do what's required. And I think for me, one of the things we've really done over the last 2 or 3 years is bring a very welcome focus in this area and to say it now has to be on everybody's agenda.
Any other thoughts on this? No.
I will just waffle, so no.
No, fine. There's a little one that's come in, maybe it follows on for what you were just saying, Chris. It's good to call for visionary leadership, but does NHSE want visionary leadership in every trust? Visionary leaders aren't always good at doing what they're told.
That sounds great.
Good leadership is surely not about an individual visionary leader. It's got to be about somebody with some vision
and somebody with some ability to methodically and carefully put in place aspects of the vision. So I think, yes, there needs vision, but it also needs people who will implement it.
I'd be really interested. I mean, I'll have an opportunity to talk to people afterwards. I genuinely feel, certainly from my point, and I accept you might think, well, he would say that, wouldn't he? I genuinely feel there is a shift in terms of a recognition in NHS England's leadership, and we've actually said it publicly, we've put it in the operating framework, that with the creation of ICSs, we genuinely need to give space to lead. That is why we are saying we are wanting to create a new NHS England that will have somewhere between 30 and 40% fewer people in it, and where we're saying we are absolutely, and we were literally discussing this at the exec group this morning, about where can we delegate more from national to region and from region to local. And I kind of accept why there may be a degree of cynicism here, but all I'm saying is from where I sit, and in the meetings I sit in with my exec group colleagues, I think there is a genuine willingness to really make that work, recognising that there will be pressures, as you would expect, at a point when we are under operational pressure. You will, quite understandably, see pressures from, for example, national government to basically say what is being delivered in these areas where it's very clear that, the NHS ideally should be providing a better performance of service.
Okay. Right, number 2, question there.
Good evening. I'm Nabil Jamshed, 2 hats on, non-exec at Black Country Healthcare and head of governance at Guy's and St Thomas. My question relates to the whole today. We heard about integration. We talked about place-based partnerships. We talked about the role of social care interacting with healthcare. But yet we hear about technological advancements, digitization, and everything else we talk about in terms of our patient data. We still refer to electronic patient record. We don't think about electronic social and healthcare record. And how do we change that as a system that we look at electronically digitizing the record access about patient health and care together in one umbrella so we can see the whole patient in one go?
Thank you.
That's the Ming for the day.
Yeah, I was going to say, I wish Ming was here, because she would absolutely kind of have a much more detailed answer. But sorry, I'm probably doing too much talking. So there's a really clear recognition, if you look across healthcare systems across the world, about those who are providing better outcomes and effectively getting greater efficiency and productivity. Data and digital are absolutely at the heart of this. And you're absolutely right to identify that data does not equal, a patient record. It's actually using data to provide, better quality care, greater insight. And that's precisely why, you just need to look at what happened in COVID in terms of, the way in which we created we were able to bring together sets of data that enabled us to, at an incredible pace, thanks to all of your participation in the trial data, to basically be able to identify which of those antivirals and those drugs were actually able to make a real difference. So, couldn't agree more. We do need to recognise, though, that as a service, we have to take our population with us in terms of providing them with appropriate reassurance that that data will be appropriately protected. And that's an issue that, we know we've not always found easy over the last decade.
Thank you. Anyone else want to add on this? No?
No,
That's fine. There's another question in the auditorium. I've got some quick ones coming in. Take another one from number 2. Who have you got there? And then I'll come to number 1.
Hi, it's Ellie Walton from NHS Charities Together. Really interesting discussion about, what's the size of the purse for health and care, and then once we know what the size of the purse is, how do we allocate and spend that? Discussion that I've been having with one of my trustees, which is slightly different, is based on how much do we want to spend per person on health and care, and then looking at how do we fund that. So looking at how much are we going to spend first per person, and rather than looking at what's in the pot. And I just wondered what the panel's thoughts on that were.
Gosh. We probably need an economist for that. And I don't know the idea of saying what is the need that we need to meet, the kind of financial cost of the healthcare we need to meet. Deciding that before you have an idea of how much money you've got to spend that need. I'm not sure. I'm not an economist, certainly not an NHS economist. I wonder how that might work. Anyone got any thoughts?
I think people have been given social care budgets in learning difficulty instances, living outside the immediate healthcare sector. There have been personal budgets available. I don't know how effective they've been or whether that's been an acceptable approach. I certainly can't comment sensibly on that.
Yeah, it's interesting, isn't it? Because everything about the NHS is operating within the confines of a budget rather than thinking, in theory, how much do we want to spend? And of course, there's been everything about the costs is changing rapidly as well.
Can I be very naughty
go on.
and just I'm going to be naughty again. Just to say a very big thank you to Ellie and everything that NHS Charities Together has done over the last 2-3 years. I mean, an absolutely amazing piece of work in terms of the amount of money that's been raised, but also particularly the degree of kind of consultation and working together that you've had with individual trusts to kind of work out what is the best way of allocating and spending the money. So, thank you.
Thank you. Number one, we've got a different questioner. Yes.
Hello, Samita Hutchison, again 2 hats, RUH Bath Non-Exec Director and Gloucestershire Health and Care Non-Exec Director. Really interesting discussion, and Bali, really interested in your thoughts about the future and sort of asking us to lift our heads and think into the future. My question relates to probably what is perceived as the biggest threat to the future. The World Economic Forum, the top 4 risks are climate change and ecological destruction. And we all know that climate health equals human health. So there's no distinction there. So the question is, what is the role of the NHS in this? It hasn't really featured much today in our conversations, and I was curious about that. So what is the role of the NHS in this, and where do we see the future with this?
Can I come in?
Yeah,
really interesting question. Wonderful stuff. And I'm doing some work at the moment with the World Health Organization on public health, climate change, and ethics. And really, there are 2 questions, 2 things. First of all, decarbonising the NHS. That's something that absolutely must be front and centre. And I believe, but don't quote me on this, that the NHS is really quite in the avant-garde on this. I believe that to be the case, and that's wonderful. So decarbonising, but there's also another issue that I think is really urgent and important, which is that climate change, thinking about climate change, is dominated by scientific and economistic paradigms. We badly need to get health in there, and it seems to me we need to get health policy in there, and there's a huge role for health professionals to get in there and to start talking about the health implications of climate change and how they can be mitigated, adapted, how public health systems and health services can be adapted to respond to those changes. Wonderful question, urgent and important.
So, one of the reasons I love my new job, Samira, is that as well as having responsibility for Bola Awolabi and her health inequalities team, I also have responsibility for Nick Watts and Greener NHS team. And you're absolutely right, Julian. We genuinely lead the world. COP27 last week, the Americans announced they're going to basically follow our procurement strategy because we've been so successful at developing a procurement strategy in terms of to decarbonise. And genuinely, we are probably the world leader, or certainly amongst the world leaders, in terms of we were the first health service to commit to the decarbonisation target that we committed to. And as I said, everybody's now knocking on our door for advice. But if I may turn it round, the reason as to why it's working is because we've got trust leadership teams recognising that it is their responsibility to ensure, again, we've set the national framework, we've made funding available, we've got a fantastic track record of actually gaining funding from BEIS's general decarbonisation and the Department of Business's decarbonisation funds, but it only works because we've got senior leadership teams right the way across the place. Jackie Daniel in Norton Newcastle was a great pioneer, for example, in this, actually doing the work. So again, I fear I'm becoming a little bit of a broken record, but just to say thank you to everybody for the work that you're doing in this space, because with our footprint and with our staff numbers and with the number of journeys, for example, we make, patients coming into hospitals, GP surgeries, etc., then actually we've got a disproportionate influence if we can really deliver our side of the decarbonisation agenda.
I think 5-6% of the global carbon budget is on health services. Is that right? Something like that. It's very, very significant.
But the other side of it is planning for what climate change is doing to health.
Yes,
and I do remember the last government at some point in the mid-2000s, and I don't know which department it was, it might even have been an economic department, putting out their forecast planning on the impact of heat waves on health and death rates and all the different ways you'd need to think about healthcare needs because of climate change. That's presumably part of what we're talking about as well.
I just wanted to congratulate the person who asked that question, because that's clearly a situation where if you don't put scenario planning into place, you can't predict what might happen and you can't plan for it. And that's an imperative, clearly, because climate change is here. But there are other areas in health which are also important, and one should scenario plan for them.
And we know that it's going to, that the burdens of climate change in health will fall inequitably, seriously inequitably globally. Also, people living in heat islands, metropolitan heat islands, who lack the resources to have access to air conditioning, which in itself exacerbates the problem. We are going to see this, again, a hardening of health inequalities around the climate change agenda. And it's, again, something we need to scenario plan for.
Final question, it's a nice short one. I thought it was quite an interesting one for the NHS. Are innovation and standardisation in conflict?
Nice.
Well, I think when you have a large corporatized structure, which is driven by a sense of commodification costs, it's very difficult to combine those two, which is why you need to hive off a bit of that organization to do its thinking independently. In each different locality, what's different in Manchester from Newcastle from London, it can't be done right across the piece as a single piece of...
Which is something that's emerged already over the course of the day, you know, the importance of taking local experience and what's required locally is part of innovation.
And what Simon's saying about giving people the independent, I mean, that's one of the, I mean, we know there is a kind of tension between hierarchy in some large institutions, hierarchy and innovation, or the ability to, you know, or kind of entrepreneurial sense. Those things can be in tension in big hierarchies, but it's also possible to to make it more modular and to give people the ability to innovate, you know, at the margins is not quite the right word, but in their own spheres of influence, to give them the ability to innovate. Systems can do that. And I think, Chris, you were mentioning, sorry, is it Simon? Chris. I beg your pardon. Chris, you know, the sense that you were mentioning that that's some of the things you're enabling people to do in NHS England.
Chris?
I think it's both and, not either or. And I think clearly we need to innovate for all the reasons we've said, but we also do need to recognise that probably one of our biggest challenges that I know we're going to have to focus on really kind of strongly over the next 18 months, 2 years, is the unwarranted variation, where effectively, particularly if you kind of look as we kind of come back from the pandemic, and if you look at the issues that we now have in terms of the need to get through those elective backlogs, the need to stabilise the urgent emergency care pathway. What is very interesting is the degree of variation that you see, and some of that is legitimate, and that's why I think the key word here is unwarranted variation, not variation per se, but we do know that this will be a very significant leadership task that we've got over the next 18 months, 2 years, is to really identify where that unwarranted variation sits and ensure that as we come back from the pandemic, that actually we regain the productivity and efficiency that we had prior to going into the pandemic.
Because the flip side of unwarranted variation, from a journalistic point of view, would be to call it a postcode lottery, which of course is...
Yeah, and you know, that is exactly as you say, a rather slightly more pejorative way of describing it.
But it's about how it might be interpreted.
And I kind of recognise that, and that's why, again, as I said, I think it's going to be a key leadership task. And I know actually we're already doing it. It's the work that, for example, the Get It Right First Time, GIRFT have been doing to really help bear down on that has been really helpful, but we're going to need to do more on it, particularly in that space of, given the productivity and efficiency hit that we've had quite understandably because of COVID, we're going to need to recover.
Fantastic. I think it's a good place to end the first day because there's so much more conversation that needs to follow from this. That brings to an end the main sessions of the first day of the conference. I hope you all agree with me. It has been a fascinating day.